Good morning, students. Today we're going to be going through Chapter 4, which is prenatal care and adaptations to pregnancy. And this is a little bit of a longer slide presentation, so give yourself some time to get through this one. So we're going to be talking about the phases of pregnancy. Antepartum is before birth, so it's once they've become pregnant all the way up until the time of when labor starts. Intrapartum is during birth. That's the part that I spend most of my time taking care of my patients, is during that birth process. And then postpartum is after birth, and this is the 6 weeks following the birth of the baby. So this is just a picture I'd like to show. It really gives an example of how things change on the inside when you are carrying a baby. So obviously this is a picture of no baby in the uterus, and you can see the bladder has lots of room, the intestines have lots of room, the rectum has lots of room, the stomach has lots of room, liver and lungs all have plenty of room to do what they need to do. And then once a woman becomes pregnant, now that you're growing a brand new human and carrying her around in your body, look what happens to that poor little bladder. This is why women have to urinate all the time. And this is, see the intestines? This is why women need to eat smaller meals. Your stomach is much smaller, it's not going to hold as much, and you have much more chance and prone to heartburn. The liver is condensed and squished, and we see more issues with gallbladder and sometimes some liver enzyme issues, called cholestasis of pregnancy. And then the lungs. The lungs are, the diaphragm's compressed and they can't expand and take a nice big breath because it's pushing against this baby. So this is one of the reasons for some of the discomforts of pregnancy, and I always like to just point that out. So the different types of prenatal care providers, you can have obstetricians that are specialists in OBGYN stuff, so taking care of the women's body. Obstetricians are actually surgeons as well. And so not only do they deliver babies, but they do cesarean sections, and then they do surgery on the female organs. Family practice physicians are not surgeons and typically don't do cesarean sections. They if you have a family practice physician taking care of you during pregnancy, they're just going to handle prenatal care and or that delivery. Certified nurse midwives are nurses that have gone on for additional advanced training to become a midwife as well. And this is what we see working in the hospitals, is certified nurse midwives. There is another type of midwife, which is called a lay midwife or a certified midwife, not a nurse midwife, or a professional midwife. And these are people that have earned their experience either through learning it from someone else, or there are some programs out there, but they're not nurses. So there's a distinction between nurse midwives and non-nurse midwives. These midwives will typically work in their own birth centers. There's one here in town that is a licensed midwife that is not a nurse but has her own birth center. And then there are lay midwives that typically do deliveries at home. And then nurse practitioners, they don't typically deliver babies, but they will do prenatal care and family planning and that sort of thing, usually work in the hospital. So our major goals of prenatal care are really to ensure that we're looking for any risk factors, looking to find out if there's something that's not going the right direction. The other thing that we really like to do with our prenatal care is to teach habits that maybe are going to be continued after pregnancy. Lots of education. We actually do still provide physical care, but a lot of it is just building up and preparing this woman to become a mother. So sometimes people think that prenatal care is not important. Sometimes culturally, you'll find different cultures that don't feel like prenatal care is important. So you might have to spend some time telling a woman that we're here to look for any problems that could potentially affect you and your baby. And prenatal care is actually very important. So ideally, the prenatal visit should start before the patient actually becomes pregnant, so that we can make sure that she's at the optimal health before she starts to try to conceive and grow a baby. But most women start doing prenatal visits, unless they're using some sort of infertility treatments. Most women start once they miss a period and suspect that they are pregnant. So preconception care is still important. Again, I talked about you need to act like you're pregnant. The most important thing I want to point out here is adequate folic acid intake. This is so important, and we do not have enough folic acid in our diet because of all of the processed foods that we use. So a woman should really be taking large amounts of folic acid things. I'm going to show you a picture in the next slide of where the folic acid usually comes from. Also making sure that her immunizations are up to date, that she is immune to rubella, which is one of those infections that she can come in contact with that can really harm her fetus. So preconception care is actually very important. So here are some pictures of things that are high in folate. Most important thing here is green. Most of the green things are high in folate. Leafy green vegetables, broccoli, Brussels sprouts, okra, avocados, bell peppers, nuts and seeds have folate. So it's really important that folate is there, because if there's a decrease in folic acid, then we can see neural tube defects, and that happens even before a woman knows that she's pregnant. So the other thing is this is a fantastic infographic about the kinds of things we want women to know with pregnancy. We want to make sure that she's getting enough calcium, that she's eating 5 times a day, that she is eating a plate full of mostly vegetable and protein with a small amount of grains and lots of fruits. Very important that she's getting good types of proteins, and that really the food needs to be recognizable, not packaged food. It needs to be things that have fewer ingredients, and fewer ingredients are going to also mean less pesticides and less chance for exposure to that sort of thing. So when a woman seeks prenatal care, some of the things that we do is we're looking at a complete physical and history, and looking at some of the things that are chronic that she might already have that could affect the developing fetus, and then talk about the things that she should be avoiding. So I hear a lot of times, my doctor told me to have a glass of wine every day. Well, current evidence says we do not know how much alcohol causes fetal alcohol syndrome. We suspect that it's a lot, but we're not sure. We also are not sure what's causing autism. So things like smoking and alcohol, which definitely affect a mother's body, makes sense that we shouldn't be doing when we're pregnant. So very important to have these conversations with our patients. So here's some of the things that we're looking at when we are doing that health history. What is her obstetric history? What is her menstrual history? What kind of contraceptives has she used? Has she had any medical or surgical procedures to the uterus? What's common in the woman's family and the partner's family? Are there certain diseases or genetic things that we see? And then psychosocial, is she excited about this pregnancy? Is this something that she planned on? So the other things that we're looking at is baseline weight and vitals. We want to see what her nutritional status is, and we're going to determine her estimated due date. You're going to see this mentioned lots of ways. Sometimes they call it an estimated due date. Sometimes you call it an estimated date of confinement, an EDC. It's an old word, but we still use it. And what that is guessing when this baby is going to be born. And we're going to talk more about that in a minute. But I think in our society, we really think that that's a contract, that when you have a due date, that baby's going to be born on that date. And that is not true. And we need to take that misconception away for women. We're going to be doing a pelvic exam on that first prenatal visit to make sure that there's no anomalies with the pelvis, that it's got an adequate size for the dates that the woman has. And then we're going to be assessing some signs of pregnancy to make sure that she actually is pregnant. And we're going to talk about some of these signs of pregnancy in relationship to what NCLEX wants you to know and what ATI wants you to know, and then what the real world is, what we do actually out in practice. So this is a picture, and I really like this picture. It talks about the different shapes and sizes of pelvises. The gynecoid pelvis is the most conducive to delivering a baby vaginally. The android pelvis is what we typically associate with a male, but sometimes we have women that their pelvises are shaped this way. There is no way for us to know exactly what shape that pelvis is until the baby has come through. We know that early on, women's pelvises can be shaped based on their nutritional status or certain activities. So horseback riders and ballerinas and yoga instructors have different musculature and can even affect how this pelvis is formed when they're younger. But we definitely want to pay attention to the pelvis size and shape on exams. So when we're doing this type of exam, there are some landmarks that the doctor can feel for to try to see if these are very prominent. These are the tuberosities and tubercles that are on that pelvis. And if they're very prominent, we start thinking, see that surface area? There's not a lot of room for that baby to fit through there. The other thing we're going to be doing is measuring the fundus. And this is something that we actually do every prenatal visit. And this is what we do is we measure from the pubic symphysis up to the xiphoid process. And the amount in centimeters should match how many weeks they are pregnant. So it's kind of a cheater way of knowing approximately how pregnant this patient is. If she has a lot of tissue, subcutaneous fat, then this is going to affect that measurement and it won't be as accurate. But this is one of the ways that we try to measure if the baby's growing appropriately for the amount of weeks that the baby is gestation-wise. So prenatal labs, and I know you've done a lot of work on this already, so I just want to say here, we do these labs for a reason. Each one of these has specific reasons why we do them, and they're very important. This is the type of thing that we need to know when you come in to deliver. It's very important that lots of these things are known. So if a woman has not gotten prenatal care and hasn't done her prenatal labs, we're going to be doing these on admission to the hospital, but we prefer that she has them done beforehand because some of them are send outs and take some time. So I know that you've gone through each one of these. I'm not going to spend a lot of time talking about them here. We'll probably discuss them in class. So we recommend that conception to 28 weeks, a woman should be having her prenatal visit every 4 weeks. From 29 to 36 weeks, we change that to about every 2 to 3 weeks. And then 37 weeks on till delivery, it should be weekly. And there are certain things that we're going to do every time they come for a prenatal visit. And that's on the next slide here. So this is our routine assessment each prenatal visit. And this is why it's so important. Remember, we're looking for problems. So we're going to see if there's any new risk factors, and we'll talk more about risk factors in a minute. We're going to be looking at vital signs and weight to determine if the weight gain is normal or if it's too much or if it's not enough. We are going to be doing a urinalysis. We're going to look at blood glucose screening to see if she's developing gestational diabetes. We're going to do fundal height to make sure that the baby is growing and there's enough amniotic fluid and not too much. We're going to try to assess presentation by using Leopold's, and we'll talk about that in a minute. We're going to be listening to the fetal heart rate. We're going to be asking her about her nutritional intake and then asking her if she's having any specific discomforts or problems since her last visit. So all of this happens in about 15 minutes. So important stuff, and we're doing a lot of it a lot of it overlaps, but it is very important to make sure that we assess for any problems that we could head off later. So again, that blood pressure is super important. Checking that patient's weight. Some patients are very sensitive at this time to their weight gain, but it is important for us to know what's going on so that we know how well the baby is developing. And then this is that urinalysis. I may have talked about this in another lecture, but you can really tell a lot from the urine of a patient. So this patient, I'm going to tell you right now, is dehydrated. This urine should not be this color. Urine should be almost colorless, maybe a slight yellow tint, especially if they're taking prenatal vitamins, if they're peeing a lot of it out. But this person is dehydrated. And that's the first thing I would look at. And their specific gravity is going to be off when they're dehydrated. But when we do a urine dipstick, especially in prenatal care, we're looking for lots of things. Leukocytes could be signs of infection. Nitrates could be signs of specific types of infection, like E. coli. And where does E. coli come? From the gut. So probably means she's not wiping appropriately. Bilirubin could be signs of liver dysfunction. Protein could be signs either of preeclampsia or blood. pH is going to tell us if also signs of infection and hydration status. Is there blood in that urine? It could be kidney stones or it could be infection. Specific gravity tells us about her hydration status. Ketones tells us if she's breaking down muscle for energy. Either she's not eating enough, or there could be some gestational diabetes going on. Bilirubin, again, looking at liver and if things are functioning appropriately there. And then glucose could tell us if she's spilling sugar in her urine, then it's not where it should be. Remember that glucose should be in the cell, not in the bloodstream. And so she could have undiagnosed gestational diabetes. So there's a lot of information we can tell from a simple urine dip. This is the Leopold's maneuver I was talking about earlier. This is showing you that by doing systematic maneuvers with your hands, you can try to determine where the baby is positioned in the uterus. And as we get further along in pregnancy, both physicians and nurses will do this sort of maneuver to try to determine where the baby is. And it takes some practice, but in the hospital, hopefully you'll get some opportunity by putting those fetal heart monitors on, and you're going to do your Leopold's first so that you could try to find that baby's back, because the best place to put that fetal heart tone monitor is where the baby's back is. So early and regular prenatal care, very important for reducing preterm delivery, for reducing babies that are born with conditions, determining those things before, and by trying to predict things like this. What position is this baby in? This baby is in a breech position, and proper Leopold's would help us to determine that. And most breech babies nowadays are born by cesarean section. We'll talk about that later. So there is more vaginal discharge during pregnancy. It's very common. We can see increased infections there, and usually it has to do with an overgrowth of yeast. And one of the ways that we combat yeast is by not eating a lot of sugar, by making sure that we're wearing cotton underwear so that there is some breathability down there, and making sure that we're washing those things in very hot water. Other things that can help: increasing your lactobacilli, which is a good bacteria that's found in things like yogurt and kimchi and some of those fermented foods. Very important to make sure that we keep our pH appropriate. We don't want to let a bacterial infection go, because there are some association with that and preterm delivery. So we are paying very close attention to that. So the role of the nurse in prenatal care is making sure that we're collecting data, we're identifying and reevaluating the risk factors continuously. A lot of times the nurse will develop a lot of rapport with this patient. They see them frequently. We are talking about nutrition counseling, and we're giving education. For instance, this picture, I picked it on purpose, that this woman has very long fingernails. We know that, and these are probably acrylic just from looking at them, we know that the bacteria that lives underneath fingernails is detrimental to babies. In fact, if you work in any mother-baby or labor and delivery unit, you will actually sign a form saying that you understand there is no acrylic nails, gel nails, all nail polish needs to be unchipped, and your fingernail cannot grow past the end of your finger, because we can actually swab bacteria out of these nails that is detrimental to babies. It kills them, basically. So this would be a good time to tell this woman she's coming in for prenatal care, and you might give her some information, not being judgmental, but just saying, I think it's important that you know that this is probably going to interfere with A, you getting this baby latched to the breast if you're breastfeeding, and B, it harbors bacteria that's very harmful to babies. And you might want to think about maybe just during this time when you have a newborn or having a baby that, you have those removed. So again, it's giving them education, giving them good information about that education, and then letting them make the decision. So here's some terms related to pregnancy that you're going to want to know, and these are in your book, but I'm going to use them. This is determining a due date. This is Naegele's rule. And you're going to hear Naegele pronounced a lot of different ways. But basically, this is a down and dirty way of determining when the baby's due month is. It's not an exact science. This is depending on what time you become pregnant in the year. You may need more time pregnant or less time pregnant. It just kind of depends on you and your genetics and your baby and his or her genetics, and again, the season that you become pregnant in. But a down and dirty way of figuring it out is you take the patient's first day of their last menstrual period, You count backwards 3 months, you add 7 days, and then that's your due date. So we'll do an example here in just a minute. I know most people nowadays use something like this. It's an app on their phone, or they might use a pregnancy wheel. So this is where you would put this arrow on the first day of the last menstrual period. And then by the time you roll around here, it's going to tell you approximately what date. Again, we need to tell women anywhere from 3 weeks before to 2 weeks after this date is normal and expected. So your baby will probably not be born on its actual due date. So here is a question for you. We're going to determine that this patient is, her last menstrual period was on June 7th. And so the first day of her last menstrual period was June 7th. So following our rule, we're going to subtract 3 months. That takes us to March. And then we're going to add 7 days. So her due date will be March 14th of the following year. Around then, her due month will be March. All right, so when we are taking the history of the mother, sometimes we will ask them their GTPAL history. And what that means is G, gravid, how many times they've been pregnant. Remember, you're gonna study those terms. T is how many term births they've had. How many babies of those pregnancies did they deliver after 37 weeks, which is what we consider term. P is how many preterm births. So this is after 20 weeks, but before 37 weeks. Abortion, the term abortion refers to any pregnancy that ends before 20 weeks, whether it is by spontaneous abortion, happened on its own, or by therapeutic abortion, which is something a mother chose to have performed. We don't use the term abortion when we're talking to parents because they think that abortion just means the kind that you choose to have, but actually abortion is an all-encompassing word. So when we're talking to patients, we'll say miscarriage if it was a pregnancy that ended without her choice. And then the L of the GTPAL is how many living children, how many current living children do you have? And this is a way of us drilling down if someone's had multiple pregnancies, what ended up happening with all those pregnancies. The reason why we want to know this is if she's been pregnant 9 times but never delivered a live child, that would definitely be something that we would be paying attention to. Or if she's been pregnant 4 times and all of them were born before 37 weeks, then we know that she's at a very high risk for another preterm delivery. So this is the kind of thing that we need to spend time talking to our patients about. So when we're talking about pregnancy, we're dividing them up into trimesters. Our first trimester is 0 to 12 weeks. Our second trimester is 13 to 28. And our third trimester is 29 to 40, or when the baby is born. And certain things happen in the trimesters. So the first trimester is oh so important because that's when the baby is really forming. And then the second trimester, from then on, the baby is just getting stronger and growing and developing those organs, but everything it needs to survive is there. And then that last trimester is when the baby's really laying down some fat and getting ready for labor and birth, as mom is. So it's important to give them some guidelines as to what to expect. Some women are very nauseous and do a lot of vomiting during the first trimester, but then start feeling pretty good in the second trimester, and then start feeling pretty uncomfortable in the third trimester because of that picture I showed you and all the different things that happen when you're pregnant. So this is where we're going to get into NCLEX world just a little bit. Some presumptive signs of pregnancy, you'll need to know that term, is amenorrhea. So the absence of having a period is what that means. And that is a presumptive sign. It doesn't mean it's a for sure sign, because other things can cause you to stop having periods. Other presumptive signs might be nausea, breast tenderness, some deepening of the pigmentation of the skin. I'm going to show you that in the next picture. Maybe some urinary frequency, fatigue, drowsiness, and feeling a little bit of quickening, which is that early movements that we first feel with when the baby starts to move. These are all presumptive signs because these things could be caused by other reasons other than pregnancy. Here's some of those pigment changes that I was talking about before. You might see the la negra that starts to change on the skin. You might see some stretch marks or stria gravidarum coming up, and then the breast starts to change. You can see non-pregnant versus early pregnancy versus late pregnancy. This starts to change based on hormones because it's becoming more of a target so that the baby will know where to find food once the baby is born. The breasts don't actually continue or finish development until you become pregnant. So probable signs of pregnancy could be a positive pregnancy test, but again, it's not an absolute positive sign because some things can cause a positive pregnancy test that is not pregnancy. Not very many, but there's a few. And then Goodell sign, Chadwick sign, Hagar sign, McDonald sign, these are all in your book. And they really just go through some old ideas before we had ultrasound, before we had good blood tests, before we had good pregnancy tests. You can get an accurate pregnancy test at the dollar store nowadays. And remember, it's looking for HCG. That's the hormone it's looking for. But all of these are described in your book. And this is really NCLEX world where they want you to know this sort of thing. Positive signs of pregnancy would be an audible fetal heartbeat, fetal movement felt by the examiner, or an ultrasound, and actually visualization of that fetus. This is called a fetoscope, by the way, and it actually is a pretty effective way of hearing that baby. So normal changes, I already talked about these in pregnancy. I'm going to spend just a few minutes talking about them here, not much. If you want to pause the video and spend some time looking at each of these in your book, you could. Same picture I showed you before, that there's lots of physiological changes that happen as that baby starts to grow and take up room. Here is before conception, and the uterus is acting as a pelvic organ, and here is almost term, and the baby is filled up and now is filling the mother's abdomen as well. Here's some effects on the endocrine system. Lots of hormones. I talked about this before. The most striking is that the placenta is a temporary endocrine organ, and it is helping us maintain our progesterone and estrogen to tell our body we need to stay pregnant. So the uterus becomes a temporary abdominal organ. I mentioned this before. The cervix starts to change in color. If someone were to care to use a speculum to go up there and look at it, it starts to change in color. There's a mucus plug that forms at the bottom of that uterus to help keep any bacteria from getting in. And then the ovaries stop production of eggs and start to produce progesterone to maintain the lining of that uterus so that the baby can grow and get its nutrients from there. So the reproductive system, we see an increased blood supply to the vagina and to the cervix, like I already mentioned, and there is increased secretions, like I already mentioned, which can help things like yeast grow. So we have to be on the lookout for that. Breasts start to change. Again, the development happens with pregnancy. This is when the breasts finish their development after puberty. High levels of progesterone and estrogen start to prepare. Those tubercles of Montgomery start to secrete lubrication. They're always there, but they become more prominent in pregnancy. So some people are very concerned that they've developed pimples on their breast, and that's not what that is. And then that pre-milk starts to happen at about 14 weeks of pregnancy. So a lot of times I deal with women right after delivery, tell me, I don't think I have enough milk. Well, you've actually had pre-milk from about 14 weeks. You just don't know how to get it out. It's very thick, and there's some specific techniques that we utilize to express milk from the breast. And so sometimes we have to help them with that and assure them that they have what they need, unless there's some risk factor that maybe they don't. This is just a really great picture of progression of pregnancy. And of course, with the new one at the end, I thought this was really well done. Here are some of the changes that happen throughout pregnancy. We like to call it nature's breast augmentation. So again, that breast is finishing development. The areola is going to become darker. The nipple is going to become larger. As we continue out on through pregnancy, you're going to see that the breasts mature in size. They get larger because these ducts are now sensitive to the hormone influence, and that's where they're starting to produce milk. And then there may even be some engorgement of the tissues after pregnancy has ended because of all the fluid, usually from what we give them in labor, but that can actually affect the baby being able to latch on. And we'll talk more about that when we get to that chapter. So the respiratory system, we have increased oxygen consumption. Sometimes a woman will have a hard time breathing, like I said before, as that baby starts to grow, and then it starts to feel, it gets easier to breathe as the baby starts to settle down into the pelvis again, getting closer to delivery. Women complain about nasal stuffiness and nosebleeds and voice changes, and this is usually related to the estrogen changes that is helping to keep our body pregnant. Our blood volume increases by 45%. And I know that we've spent a lot of time talking about this, but the reason why it increases by 45% is because now it has to circulate to people rather than just one, and it's in anticipation of blood loss at birth. So you might see a pulse rate increase by about 10 to 15 beats a minute, and that's normal. But the other thing that we see with this is a decrease in iron, because it's too much volume and not enough iron. And so women become tired more easily. They sometimes have a hard time climbing a flight of stairs because they don't have enough heme, which is what the oxygen attaches to, in order to circulate around the body. We call this anemia of pregnancy. This is what we call, I like to show this picture because this is what we call supine hypotension syndrome, or vena cava syndrome. And so this is why we do not recommend that pregnant women, especially second trimester on, lay flat on their back, because you can see that this baby is laying on this vena cava, and that is going to affect the mother's ability to circulate her body and the baby's body. So if a mom wants to lay on her back, we just put a little bit of a wedge here so that she's slightly tilted, so the baby's not pressing on that vena cava. It can happen, it can lead to fetal hypoxia, it can cause symptoms like the patient feeling faint, being lightheaded, being dizzy, being very agitated. The cure is just turn them over so that there's blood flow. This is how a woman should be resting on her side. This is the appropriate way. And you can see that the tummy is well supported. She's not pressing on that vena cava. Her legs are well supported, and she's comfortable. So again, we can, with the cardiovascular system, we might see palpitations because we have that extra blood flow. We have dilutional anemia. We've talked about that a ton. We also see increased clotting factors in the second and third trimester in anticipation of this mother who's going to be delivering soon, where we do want her to be able to clot. But the other side of that coin, the possible problem with that is she has much more chance of having like a DVT or throwing some, or a PE, some other kind of clot. So it can, it makes it a little more dangerous. This is why we recommend that pregnant women don't travel for long periods of time, that they get up and stretch if they're still at work, that sort of thing. So on the gastrointestinal system, I already talked about this a little bit. I'm going to let you pause this video if you want to spend some time talking about this. The urinary system, the mother now has to take care of the waste for the baby as well as herself. There is an increased chance of UTI. And we also see that the woman will retain more fluid. And so this is part of what causes the swelling of pregnancy, especially in dependent areas. So many women experience swelling towards the end of pregnancy, but we need to be on the lookout for that, because that can actually be a sign of developing preeclampsia. So the effects on the integumentary system, there can be lots of things that happen to the skin. And this is usually the thing that the mothers are most concerned about, because they're worried that these things won't get better after delivery. And most of these go back to normal. Some of them you might have, they'll fade, but they might stay. So striae is one, spider nevi is another. Women become, the sweat glands become more active. So typically they will be sweatier. So here's the spider nevi that I'm talking about. This is the mask of pregnancy. This is based on hormones. It's also called melasma, and that's the medical term for it. This can be very upsetting to women, especially women that don't wear makeup. And this does fade when those hormones go away. Here's that linea nigra again, going right down the tummy. Why it's not straight, I don't know. This one's not straight up here, but these are normal effects of pregnancy. And here's what those stretch marks look like. Stria gravidarum, This is when, with the pregnancy, they can become red and kind of inflamed, and then usually they will become a silvery, faded look to them once the baby has been delivered. And then the effects on the skeletal system can be huge. You can see this woman has a sway back because she is carrying the weight of this baby out front. So there could be posture changes, lots of low back complaints. There's relaxation of the joints because of another hormone called relaxin. And so that is what gives us that waddling gait, where you can see that a pregnant woman is pregnant from just by the way she's walking. And that actually affects all the joints and cartilage in her body. It just allows it to have just that little bit more of a give in anticipation of delivery. But there's also changes in the center of gravity. So balance can become an issue. We tell women, please don't climb on ladders or climb on things. Because you can fall off. Your center of gravity is definitely off. And that's what I'm talking about here. And this is one of the really important things in prenatal education, is talking about what's normal, what's not normal, telling people what they need to be reporting. So here is some nutrition again for pregnancy and lactation. Anything you ate while pregnant, you can eat while lactating. I always get this question, what should I not eat when I'm lactating? Well, what did you not eat when you were pregnant? Those are the kinds of things that you should pay attention to. When you're pregnant, it's a main line to the baby. When you're lactating, it goes all the way through your digestive system and then into the mother's bloodstream before it even thinks about getting to the milk. So again, you see that at least half of this plate should be vegetables and fruits and good sources of protein, and then whole grain breads and starchy vegetables. Those are where you're going to get your vitamins. Healthy weight gain is going to be based on what the mom's BMI is at conception. And we're seeing so much research about the obese patient that's getting pregnant and the different problems and concerns that we're having during pregnancy and during labor and delivery, and even to the fetus afterwards. So somebody that is at a healthy weight, which is a BMI, a healthy BMI under 25, should be gaining about 25 to 35 pounds during the pregnancy. Someone that is underweight should be gaining about 40 pounds, and somebody that is overweight should only gain about 15 to 25 pounds. And your weight gain is going to be based on what you put in your mouth. That is 100% how we grow these babies. Your body's going to give the baby what it needs, but if we're eating excessively, eating lots of carbs, sugar, that sort of thing, we get more than we need. That's where we are going to pack on the weight and not the baby. So they need about 60 grams extra of protein a day. Calcium needs are very high. Where do we get that calcium? Leafy green vegetables. You got it. That's right. Folic acid needs are higher. Where do we get that? Leafy green vegetables. And then iron. What kinds of foods have iron in them? Beans, fortified cereals, whole grains. A lot of the food that you get from WIC has iron in them. Lean proteins. Those are all good sources of iron. So special considerations, things that we need to be thinking about when we have a pregnant adolescent. We have somebody that is trying to maintain her own body weight and her own growing and grow a new child, a new human as well. So that is very important. And teens are not necessarily the best having the best diet. We need to be looking at vegetarians and vegans. They have specific dietary needs in pregnancy. It takes a lot for them to get their B vitamins, because that's typically, we get those from protein sources. So if they're not eating any meat at all, they're going to have to get their B vitamins replaced. Pica is one of the things that we see in pregnancy quite a bit. This is usually related to a lack of some sort of nutrient that the patient is not getting, and they start having cravings for things that are not usually considered food. Usually it's starch or ice off the freezer. Kind of an old idea. We don't really have ice in the freezer anymore. Dirt sometimes are things, and they're worried about telling us because they're embarrassed, but this is pretty common. And we want to make sure that they're getting a good vitamin and eating a proper diet. People that have different cultural preferences, there's a lot of myth around what needs to be eaten during pregnancy and right after birth in regards to culture. It's not going to hurt anyone. Most of the things that they do are not damaging to anyone. The only thing that can be specifically an issue is in certain Indian cultures, they'll want to put honey in the baby's mouth right after delivery. And honey is not to be given to young children under the age of 1 because of the chance of botulism. And then gestational diabetes. This is somebody that has a diabetic syndrome while they're pregnant. And these women need to follow their diet very closely. We're going to talk about more about infants of diabetic mothers when we get to the chapter on complications. These are different types of pica. And yes, some of these are very disgusting. We don't see all of these all the time with women. But like I said, the ones that are common are starch, clay, chalk, ice, that sort of thing. And again, it's because they're lacking something in their diet. So what we say about exercise during pregnancy is that if you were not a marathon runner before you became pregnant, now is not the time to become a marathon runner. So if you have been very active and you have already been doing yoga and already been exercising a lot, there's no reason not to, unless you start having signs of preterm labor or vaginal bleeding, then of course you're going to stop. But being active and moving is actually very important to help that baby get into the optimal position for delivery. When we talk about air travel or any travel during pregnancy, it's very important to tell women that they need to take their prenatals with them, because all those labs and everything that I talked about that need to be done early on, if they don't have a copy of them, and we see this all the time, people traveling through here and then something happens and they need to be seen and we don't know anything about them. So we need their prenatal records with their prenatal labs. It's important for them to bring that with them. And then they want to avoid sitting for extended periods of time and making sure that they know what kind of local infections are in that area. Zika is a huge issue. It's even here in the United States, but we recommend that women are not traveling to these countries that have large populations of Zika virus right now, because we know there are extreme risks to the baby, and we're going to talk about that later. And then we talk about what an oral rehydration formula is, especially if they're going to a third world country. Dehydration is detrimental to a pregnant woman. And everyone should know what the oral rehydration formula is, and it's here on the next slide. Basically, you take 4 cups of clean drinking water, mix 1/2 of a small spoon of salt and 6 small spoons of sugar, and that's your oral rehydration. This is for anyone that's dehydrated. You've got to put some of that sodium and glucose back in there. And so just water is not enough if you're dehydrated. You've got to put some of those electrolytes back in. This is homemade Gatorade, basically, without the food coloring and chemicals. So other common discomforts that we see in pregnancy, all of these are common discomforts. We try to tell women that these are to be expected. We're not concerned about these. I'm going to let you pause the video and spend some time looking at those. You can also read about them in your book. But I want to spend some time here. Every woman should know warning signs in pregnancy, and these are the type of things that if they happen, you need to go immediately to either the birth center, the nearest hospital. It's not wait until my next doctor's appointment kind of thing. If any of these things are happening, we want to see you right away. And so every pregnant woman should know about the warning signs in pregnancy. Visual disturbances, that seeing spots or feeling like your peripheral vision is going away, or just feeling like it's blurry or not off. A headache that doesn't go away with Tylenol. Extreme edema. You've suddenly just blown up and your feet are blown up, or you've got edema in your face. All of those could be very severe signs of rapidly changing preeclampsia. And so we want to have these women come to us so that we can rule that out. We would rather that they come to us 50 times and everything be okay than them not come the one time. Rapid weight gain. They've gained more than 3 to 5 pounds in a week. It's probably swelling and edema, and we need to look at that. If they're having extreme pain, either epigastric pain or contraction pain or a backache that just will not go away, could be signs of preterm labor, or again, signs of preeclampsia. Any sign of infection, we need to figure out why, what's infected, and we need to treat that. Women that are pregnant are at higher risk of developing infection and sepsis because their immune system is depleted. Vaginal bleeding or drainage. If there's bright red blood Running down your leg, that's an emergency. You need to come in right away. Sometimes after an exam, when a patient wipes, there'll be a little bit of blood on the toilet paper. That's normal, but bright red running down your leg or filling a pad is not okay. Persistent vomiting, you're going to change your electrolyte balance. We need to fix that. Muscular irritability or convulsions could be a sign of preeclampsia or eclampsia. And here's the most important one: absence or decrease in fetal movement once it's felt. When a baby becomes stressed, the first thing it does is it slows down all of its movement, trying to conserve its energy, trying to conserve everything that's happening on the inside. If we can get to a baby at that time, we could potentially save this baby's life. But if you wait 2 or 3 days and don't come in to be seen, your baby's going to be gone. And I can't tell you how many times I've taken the phone call, I haven't felt my baby move in about 3 days, and my heart just sinks. And all I can say is you need to come to the hospital as soon as possible. If a patient calls at all, that's all we can tell them nowadays, is if you felt like it was important enough to call, you're going to need to come to the hospital. So there's some different maternal responses that can be happening. She might be ambivalent to the pregnancy. She might be very introspective and wanting to do things the same as her parents or different than her parents. She might be accepting and excited about the pregnancy. She might have mood swings between all of these things, and that's normal. This is the process of becoming a mother. And then as her body starts to change, she may become more emotional about that as well. Some women's self-esteem is very much tied to what they look like. Pregnancy and sexuality, there's no reason that sexual activity cannot continue as long as there's no leaking of fluid or bleeding. If there are some other circumstances, history of preterm delivery, it would be a reason not to have intercourse. But if any of those things happen, then we should direct them to talk to their physician before they resume sexual activity. So how does the father develop? Well, when the announcement of pregnancy is confirmed, sometimes they're still in a denial phase all the way throughout the pregnancy. And it's because they don't feel this baby moving inside them. They don't have the same interaction with the baby when it's on the inside as they will once the baby's born. So most fathers nowadays are very actively involved in getting ready for the birth, getting ready for the labor, getting ready for the baby to come, but don't actually get to that point of acceptance until the baby is born. I actually really love that part. When the baby comes out and then you just look at the dad, they burst into tears because it's really real for them at that moment. It's one of my favorite parts. So the adolescent, there is all kinds of issues that may come along with this. Some adolescents may be happy about the pregnancy. Some families may be happy about the pregnancy, but we have to consider her developmental level. Obviously, if she's 11, it's going to be different than if she's 17 or 18. She's going to have to cope with 2 of the most stress-filled events at the same time, which is adolescence and parenthood. Hopefully her parents are supportive of her. I've seen many times where the parents kind of feel like, well, you got yourself into this mess, and they can be almost cruel to them during labor. I always try to be their advocate. There's no reason to punish her now. This is not the time and place. A baby is coming, and all the repercussions of that are going to be happening. So she needs support. And then the impact on the older couple. We actually see this more often now than we do teen pregnancies, is women are delaying their fertility, and they may wait until their 30s, 40s, or 50s to deliver babies. Yes, 50s. I've had several 51-year-olds in the past couple of years. Typically don't use their own eggs, but will carry donor eggs to delivery. And these are women that typically have lived an entire life. They've been professional, usually they're educated, they're used to things going their way, they have very full planners, and the unpredictability of pregnancy and childbirth and child rearing can sometimes really throw them for a loop. So they have their own issues to deal with. And let's see. There's lots of reasons people are delaying childbearing, and I'll just let you spend some time looking at this slide. And then the impact on grandparents. We see grandparents involved in labor and delivery quite a bit. You'll get your experience there. Sometimes they're very helpful and amazing at the delivery. Sometimes they are very intrusive, and we have to kind of advocate for the new parents that this is their time to do things their way. So this is another dynamic and that comes along with being a labor and delivery nurse, is dealing with the extended family as well. And that also includes siblings. So sometimes there is excitement on the part of the sibling until the baby's actually here, depending on how old that sibling is. And so it really just depends on how long they've been an only child. If this is their third or fourth or fifth sibling, they're usually not as upset about it, but they're usually very excited to come see their mother. And so we try to make sure that it's not scary when they come in to see their moms, that there's nothing that looks very medical to them, because of course they associate medicine and shots and IVs and that sort of thing with pain. And so we want it to be a happy time for everyone. So what is the point of preparing for childbirth? Well, the biggest thing is to know what's going to happen. There's lots of choices that need to be made. Are they going to be bottle feeding? Are they going to be breastfeeding? What should they expect in labor? There's lots of good information in childbirth education, but unfortunately, less than 0.5% of the people that deliver at my facility come to any sort of childbirth education. It's really a shame. We spend more time learning how to drive than we do learning how to deliver and raise a child. So we highly recommend some sort of class. There's lots of good sources on YouTube. I put some of those videos actually in your YouTube video list. So babycenter.com is another place that you can spend some time seeing some of these videos, but we really recommend that women not just show up and expect to learn everything they need to in the 24 to 48 hours that they're going to be with us in the hospital. They do need some preparation for this major life event. So when we talk about drugs and pregnancy, medications and pregnancy, your drug book is going to list things like category A, category B, category C. Most drugs are going to say not recommended during pregnancy. Now, there are some that the benefits outweigh the risks, and that's something that a physician that is prescribing these medications certainly would be having that conversation with this mom. Unfortunately, there are times when we don't know what the risk of the medication is until it's been given to lots of women. I'm sure you've seen some of those in the, they throw those ads up on TV trying to get people that have been damaged by them. But there have been times throughout history that we've given medication not understanding that there was a huge risk. One of those medications is Accutane, and that's a pretty common medication. It's used for acne. It is a category X. There is absolute fetal abnormalities or death with the use of that drug in pregnancy. So you cannot become pregnant while taking Accutane. Another one of the medications that's no longer on the market and used for this was thalidomide. And thalidomide was a medication that was given for nausea. And so they were giving it to women early in their pregnancy. And there was a whole generation of children born without arms and legs. I have a picture of that on the next slide. And so sometimes we don't know what the risk is. So we highly recommend, unless there's a clear indication, and this goes for over-the-counter medications as well, unless there is a clear reason that the benefit is going to clearly outweigh any risk, that we recommend they don't take anything other than their prenatal vitamins. So here's a picture of the thalidomide babies. And these were babies that were born with no arms and no legs. There were actually there were thousands of them that were born. And if you want to spend some time looking at that online, it's pretty interesting. So then we move into lactation drug risks. And so when we are looking at medications that mothers are taking when they're actually breastfeeding their babies, this is compared to pregnancy risk categories. We do L1 through L5, and this is based on a book by Thomas Hale. It's called Medications in Mother's Milk. It comes out every 2 years. So I do believe that 2017 is the most current edition. But this book is the Bible for trying to decide if there's been any long-term research about this medication and being in the milk supply. Again, when you're pregnant, it goes directly to the baby through the umbilical cord. But when you're breastfeeding, there is some delay. It goes through the maternal digestive system and then into the bloodstream, and then very small amounts into the milk. So one of the things if you talk to any physician, they're going to say, just don't take the med when you're breastfeeding. Sometimes pharmacies will say, I don't want to prescribe this to you if you're breastfeeding. But really, we need to come to a source like this that has done research on these different drugs. And so lactation consultants have access to this book. Some good pediatricians have access to this book, and we'll review it. I use it all the time in my practice when I'm working with new moms. And then we have immunizations in pregnancy. It's very important that a mother have all the immunizations that she is going to need before she gets pregnant. Like I said, MMR we want to make sure that she is already immune to rubella, and that's one of the things we test in the prenatal labs. We do not give any live virus vaccines during pregnancy. So MMR is one of those that is live, so we do not use that during pregnancy. We try to avoid pregnancy for at least a month after an MMR vaccine. That's important to know, because you'll be giving these vaccines after they've delivered in the hospital, trying to catch them before they have their next baby. And then there's certain vaccines that we really would like to see given in the end of pregnancy. One of those is influenza and Tdap. We know that if we give a mother in her 3rd trimester the influenza vaccine and the Tdap, that some of that immunity is referred to the fetus. And so when the baby comes out and cannot have those vaccines for itself, it has some of that immunity from the mother. And that's very important. Tdap is, we eradicated pertussis, which is whooping cough. And then a lot of the anti-vaccine movement brought people that aren't vaccinating at all. And so now we have a rampant resurgence of pertussis right here in Kern County. We had a baby die last year that it was because the parents spread pertussis to the baby, and there were no immunizations anywhere, the family or the other children. So very important that we discuss this, and we're going to spend some time talking about some of the myths and urban legends that go along with vaccines in class when we have the discussion. Okay, that's the end of this lecture. As always, if you have questions or need more information, you know where your resources are.